The Vermont Healthcare Committee. Today is March 22nd, and what we're May 22nd. And what we're going to talk about this morning is workplace violence, and in relation to a bill H 259. So with that, we have a witness, Lisa Pucker. On Zoom, everybody is on Zoom. So if we could have Lisa come up and.
Good morning. Can you hear me?
Yes, we can, Lisa. Thank you very much for agreeing to do this. And we will listen very carefully to everything that you've got to say.
Thank you
So
for that.
whatever you want to say, you go right ahead.
I just want to start off by saying thank you for having me. And by speaking out, I don't wish to point any blame or anything of that sort on anybody or any facility. I just want to share experiences so that we can improve safety at Vermont Psychiatric Care Hospital. That's what we care about most, is safety for staff and patients together. I made the decision to attend this meeting to advocate for improved safety. At VPCH, currently we have the capability of supporting up to 21 patients at a time in their recovery. We have staffing ratios that look good on paper, but in reality, the level of safety amongst numbers is not always the case. A lot of times there are shortfalls on the units. When acuity is high on a unit, we may call over support, and that leaves other units with less than ideal staffing. Sometimes staff have to sit in with ancillary staff to meet with patients to give support. And at times there's 2 meetings, and this can leave the ratio of only 2 staff on the floor with up to 8 patients that are all in various areas of care. I fill in as charge and supervisor regularly, and I typically will put my stronger and more experienced staff on different units depending on acuity. This is something that is not automatically done by staffing. I try to spread out that staff equally, but most of the time when we had a very difficult patient recently, we were left with limited experienced or stronger staff members. Recently, we cared for a young male patient that was there for many months. This patient was very strong and basically became inhuman during EIPs. They were extremely violent, and sometimes it took more than 10 to 12 staff, including 5 or more strong male staff, to gain control over them. This is a huge safety concern. Most of the time on the unit, we had maybe 1 strong staff member, and the rest were not as capable, and this puts many at risk, including other patients. The other patients were not willing to come out of their rooms out of fear. They stayed cooped up in their rooms during what is supposed to be a time of healing and recovering. They feared for their lives. Then we had other patients that had personality disorders that would purposefully antagonize that particular patient and try to get that patient to attack staff or cause an EIP. Over 20 people were injured by that one patient that I believe had well over 50 to 100 EIPs alone, sometimes multiple in a day. The doctor attempted to change medications multiple times despite the RNs recommending not to, because we had noticed a trend in increased EIPs when they decreased a specific antipsychotic med that was seeming to help. The RNs, including myself, at times had to beg and plead for PRNs. This phone call alone took time, and for the doctor to put in the order took more time. Waiting for pharmacy to approve it took more time. This process sometimes took up to half an hour to an hour when we should have just had that available to us from the get-go. Multiple staff also begged for this patient to be put on a separate unit for the safety of other patients and to reduce trauma for other patients. This would have reduced the risk for staff being hurt until more staff could arrive on that separate unit and support them. When this was shut down, we asked for more staff. We did not get the approval for this until more people were hurt. We begged for anything to happen to get him out of there because he was going to kill someone. He wanted to kill someone and had attempted to on multiple occasions. I witnessed several of my work family get hurt during these inhuman episodes. When I covered as an RN supervisor, there were times when I called in extra support or standby. Later on, an email went out saying that it was recommended not to do this because it could burn out staff, and I think the cost of it was mentioned. That hurt my soul. We as staff are a work family. We want everyone to go home at night to their families and their pets and livelihoods intact, not hurt. And it left me feeling hopeless, and many other covering supervisors and current supervisors feeling hopeless. How can we keep our staff safe when we can't get extra support? We just wanted to go home to our families, pets, livelihoods, all of us. We begged for the patient to be discharged in any way that could happen. We begged for more staff. We suggested building a team of mental health specialists that would be specifically on acute units to help for that reason. Staff injuries so far include multiple concussions, lacerations, bites, contusions, back injuries, shoulder injuries. One staff cannot return to the job because of it. A couple others are out at this time, including myself. Please bear with me as I continue. On April 22nd, I was covering as charge nurse when I was assaulted. The doctor and I had just assessed this patient for safety to go to the yard, and we deemed it was appropriate at the time. Patient had been targeting the lead staff member all day, so I decided to go out with two other male staff members to avoid the lead being the target. The patient played basketball normally by themselves as we observed. The patient then walked over to us and I asked if they were ready to go inside. The patient mumbled something and then walked back over to the court and dribbled the ball a few more times, then walked back towards us, threw the ball down, and then went to assault a male staff member, Marvell. I called the emergency as the other male staff attempted to help the other staff. By that time, the patient had Ron on the court and was on top of him, trying to kill him by choking him. I tried my hardest to pull him off my coworker, but I was no match. I was elbowed in the head, and he used his body to push me back, to which I fell on my right shoulder and leg. And then from there, I held on to his arm for dear life while he continued to yell that he was going to kill us and tried to bite us and attack us. More staff came to help, and that's when they told me he was secure, and they asked They wanted me to get out of this situation. They helped me. I then immediately checked on my coworkers, Ron and Marvell, to see if they were okay. Ron was bleeding profusely from his chin, so I took him inside to clean him up. I noticed he needed stitches, and when I tried to clean him up, I noticed I was in severe pain. We went to the hospital. At this time, I am still suffering side effects from my head injury and my shoulder. I have to go to multiple appointments every week that I have to find rides to because I'm not able to drive at this time. Since my time at VPCH, I have heard many testimonies from my work family that still work there and dedicate their lives to that facility. Some that have TBIs that they still struggle with, some that still take beatings and come back to work because we love what we do. I also want to speak about a colleague of mine that was assaulted by a different patient in October, very savagely, on the 20th of October. They are still out after having bilateral brain bleeds and a midline shift. I still have PTSD from that day, and I'll never forget the night at the hospital when I thought I was going to lose her forever. She's still unable to work over 6 months post-incident. Most of the staff at the hospital are dedicated and love what we do, but we all worry every day about our safety. This will not be the last time we have patients like that. We need to figure out how we can increase safety measures and improve training. Safety of staff and other patients is always our priority, but we need more tools in our toolbox. Thank you for your time. Not every injury can be prevented, but we can work together to improve safety and reduce the chances of significant injuries. That's all I have.
Thank you, Lisa. Thanks for sharing that with us. Questions from the committee? Alyssa, you may go.
Thank you. Thank you so much, Lisa. And thanks for your bravery in coming here today and sharing this with us. You said at the very end that you need more tools in your toolbox. Can you tell us where you think you don't have the tools, where there are barriers to be able to use the tools you have, and what tools do you feel as though you might need?
I believe, care differs between different states and hospitals, but at the psych hospital, I know we're a different entity and there's different things we cannot use, but I just feel like we could use more staff, better training, more staff that are specific. It would be known as security, but we don't want to view it as security. I think it would be more therapeutic to just view it as acuity specialists, is what I saw in another state hospital a few years back. They helped out on the floors where acuity was the most. They participated in the trainings. They taught the trainings. They did practice with all the staff members when things were less acute. They drilled everybody all the time, and they could change and make improvements to how we do restraints. I know there's laws that prevent, I think, the use of certain tools, so I won't speak of that because I don't think that will change. But I think it starts with budget for more staff, more training, and retaining employees would be helpful. And then one more item I don't know if we can get help with, but it is a huge contributing factor to safety and dignity of patients is the law about court-ordered medications and how we attain them and how rapidly we can attain court-ordered meds. I think it's important that we look at that too, if we can.
What sort of training do you receive now?
At this time, when we get there, we have classroom training for, I think, 32 hours or more in a classroom setting, which is a pretty good overview of what we're doing. And then we have what's called PROACT, which is the overall program used to essentially de-escalate patients, and then how we would approach an emergency involuntary procedure, which is known as an EIP, when the patient loses control of themselves. And we would physically intervene at that time. I believe it's a few hours worth of training in a group setting with the instructors. But I personally feel, and a lot of staff, probably 50% or more of them can agree, that the program needs improvement. It needs more techniques involved, more staff that participate in EIPs regularly, that see how things go to help training. If there was a special team of more trained people to help out on the units to add to the staff that are already there. When I mentioned earlier, there's a shortfall at times. If we had that team in place, it would help.
Thank you.
Lisa, how long have you worked at the hospital?
So I personally was a travel nurse since July of 22. And then last year in July, I became a permanent staff member because I really enjoy what I do in the hospital. Besides what's going on, it's still I enjoy working with my work family, the work we do with our patients. It's rewarding despite some of the challenges we face every day.
Yeah. And Lisa, as you were testifying, you talked about things that you've seen in other places. Have you done the same kind of work in other hospitals?
Yes, I worked at Dorothea Dix in Maine for 6 months, and then a state hospital in Pueblo, Colorado as well for 3 months. And in Maine, they have what was called acuity specialists. And I think I've shared that idea. And another coworker of mine has shared a similar idea with administration. And I do feel that they're looking into it at this point in time, but I don't know how far we can get with that. I feel like if we had support from all avenues, it would work better.
Yeah. When you, no, before I get into my line of questioning, other questions from the committee? Go ahead.
Hey, thank you. Thank you so much. It's a really powerful moment to hear your experience. I was wondering if you knew, and you may not know this, but how many open positions there are in the unit? Have there been difficulty filling them, and, you know, sort of that kind of like those ideas, which may not be something that you know.
Um, Off the top of my head, I know that there's several travel staff open positions. I'd say there's several. I, probably 40 to 50% is my best educated guess at this time. We just had a nurse supervisor quit on the day shift.
So just so I
And
understand, 40 to 50% of what? What are you thinking?
the positions, I know there's several mental health specialists or techs that work the floor every day, all day. There's, I'd say, half the staff that we do have on a given day are travel staff,
Ah, that's huge.
as well as nurses, RNs. Um, yeah, I mean, it's growing. Our permanent staff has grown over the past year. And, that definitely happened after there was some monetary incentives, like not incentive, but increase in pay. Yes, that's going to happen. But we have to retain these staff as well, because some have gotten done for various reasons. It's hard to retain people too, and defer the veteran staff to stay. Um, Especially like if we're not able to handle those situations, the veteran staff need reasons to stay as well. They, you know, just
Thank you. Thank you very much.
Lisa, any other questions from the committee?
I'm just curious, is there an after action report on these instances? And where are they filed? Or is there even after action report?
yes. Typically the supervisor is responsible for having a meeting afterwards, like a debrief afterwards, to go over what went well, what could go better, how we can improve, how, for suggestions. And if somebody's not comfortable with speaking up, then they have an after action report they can fill out anonymously and give to the supervisor. Then we upload all of it to the computer and it's sent out to a review team, which is people in the hospital, administration, and I think the commissioner. And then I think advocates have access to it as well. And then I know the hospital has implemented a couple debrief meetings, especially after that very difficult patient left. They're trying to get input and debrief with us about it, which is nice.
Lisa, oh, I'm sorry, go ahead.
So with these debriefs and reports that are uploaded, does anyone from the hospital senior staff come to talk to your group? Has the commissioner ever come and visited after these particular events that have occurred?
In the I know after I was hurt, a lot of people were angry, not just because I was hurt, but because I think they had enough and they got angry. And I think that's when people did finally come, the commissioner and other people, the week after, and the patient, I think, left that week. Maybe I think that was, yeah. I'm not sure what kind of legwork happened. I wasn't there, but I do know they left that week and they finally came and saw how bad it had gotten.
And has anything changed since the commissioner visited?
I can't give you a good answer. I
She
haven't
hasn't been
really
there.
been present there. I just see my emails. I attended a debrief. I think they're trying to work on things, but I don't know how fast things can happen. I don't know what limitations they have.
Okay, thank you very much. I'm very
Well-
sorry for your injuries.
Mhm.
Lisa, you talked about training a lot. Everybody that comes into that hospital gets a certain amount of hours of training.
Yeah.
Now, has that training changed while you were working there? Did that training change at all it didn't?
So I
go
want to
ahead.
speak about that though. So the training has not changed itself. It's the same. There were a couple staff members that took initiative that participate in EIPs regularly, and they were downright passionate about safety and looking for ways to improve. And they were willing to adjunctly do on the spot monthly trainings with staff that needed it, or, you know, to help people take the time for one-to-one or in a small group, pull them aside and work with them. That doesn't happen right now. It hasn't happened, but those two staff were willing to do that. And it was happening until it was shut down for one reason or another. I'm not exactly sure what happened, but it was shut down last year, I think in the summer, which it only went on for a few months. And then since then, they have asked that the lead staff do pull aside trainings with staff, which I think is fine and dandy, but you're pulling more and more staff from the units when we should have them all present. I just feel if there was more staff team set aside for that specific trainings, they could go around and have time to do it. And I mean, we get a refresher for 4 hours every year. That's mandatory, but that's at the least. There should be more training, more drills, just and not just when we have bare minimum staff. It, you know.
Are there any other questions from the committee? Is there anything else, Lisa, that you would like to share with us?
Nothing that I haven't already shared. I just
Okay.
just really truly hope we can work together to do something.
Yeah. Thank you, Lisa, very much for taking the time to come and talk with us and share your story and all the other information that you gave us in terms of what's going on there in the hospital. And we all hope that you get well as quick as possible. Thanks
Thank
very,
you.
very much. Thank you.
Thank you.
Okay.
People? Yeah.
Sure. All right, so we have next Karen Barber. Hi,
Good
Karen.
morning.
How you doing?
How are you?
Good. Did you just hear that testimony?
I did.
Okay. Okay, so could you talk to us about who you are, what you do at the hospital, and some kind of response to that? What's going on at the hospital to improve on that situation? My understanding is upwards of 30 people have had to go to the emergency room over the past year because of injuries. And if that's wrong, then you can correct that, but please
Sure,
fill us in.
sure. Good morning. For the record, my name is Karen Barber, and I am General Counsel of the Department of Mental Health, or DMH. I think we were invited here today to talk about Act 9 or S-259, which I think is part of this. How do we respond to workplace safety? I did want to kind of highlight the work that BPCH is doing around that. Before I kind of get into it, I do have some folks from VPCH here today with me today, so I wanted them to introduce themselves first, and then I'll start in testimony in depth. So, Wendy, do you want to introduce yourself first? Oh,
Sorry about this.
do you
Okay,
just
I'm
want to
hoping.
introduce yourself, Wendy?
My name is Wendy Shapiro. I'm the Chief Executive Officer at Vermont Psychiatric Care Hospital.
Grace?
Morning. For the record, I'm Grace Winters. I'm the interim chief nursing executive at the Vermont Psychiatric Care Hospital.
And Nicole?
Good morning. For the record, my name is Nicole Garcia. I'm the Hospital Operations Director and member of the VPCH Safety Council.
Okay. So before I started, did just want to kind of mention three kind of broad things. One, we won't be commenting on any specific patients. Both federal and state law limit our ability to discuss cases. But I do want to acknowledge that when we have high acuity patients, it is incredibly intense and stressful at the hospital. And when staff get injured, it's traumatic for everyone. And we can't acknowledge enough how hard our staff work in challenging environments. And I know that I think there'll probably be some follow-up questions around staffing, and we're happy to get into that. I do just want to note that VPCH actually has the highest staffing ratio of any level 1 unit in Vermont. And then to back up a little bit, I know that, because we've been following these bills as they've worked through the legislature around workplace safety in hospitals. ED, and I think most of that testimony has really been focused on emergency departments, which makes a great deal of sense. I'll say, though, that inpatient units, which is what VPCH is, are very different. They're much more contained and secure. We make admission assessments before individuals are admitted. We've reviewed records. We likely know what their needs are. We are designed to serve folks for longer periods of time. We have lots of specialty trained staff. And we have the ability to have our environment that we also use to make things more therapeutic. We're also, as a locked facility, no one can just walk into our facility, so we're able to really restrict who comes in and out. And the last thing that I want to note, because I think it's important to always kind of frame things this way, is that individuals with mental illness are much more likely to be victims of violence than to commit violence. I think that's always important to note. So who do we have at VPCH? Because I think that's really part of the question, right? And so when folks are at VPCH, they are involuntarily under our care, and they've come to us because they need help. They have mental health needs that have reached such a level that they're a danger to self or others due to mental illness, and both clinically and legally, they have met the standard for the most restrictive level of mental health treatment, being involuntarily hospitalized. And our job is to provide that care in the most clinically appropriate and least restrictive way we can. VPCH is known as a level 1 unit or a level 1 facility. So we, along with Brattleboro Retreat and Rutland Regional Hospital, have level 1 beds. And really that's a contract term, but what that means is that we are designed to serve the most acute individuals in Vermont, and we have higher staffing ratios. VPCH is somewhat unique in that we are the only facility that only has involuntary individuals, and we only have level 1 patients. Because of the patient mix we have, it does mean that sometimes individuals act in an unsafe manner and they put themselves and others in danger. And while there's no way to completely eliminate that risk, VPCH, like all hospitals, does do a lot of work to mitigate that risk in terms of staff training, facility layout, and the clinicians that we have on staff. The work is really hard, and there is an inherent risk of being injured. Our staff do an amazing job in a really challenging work environment. But sometimes, unfortunately, people do get hurt. I can tell you that every single person in leadership takes that incredibly seriously and is constantly thinking about ways to improve things and make the facility as safe as possible. The commissioner and I both get notified as soon as there is an event, and we're constantly in contact with Wendy and other leadership at VPCH. So while I'm here to talk about all the different things VPCH has been doing and will continue to do in terms of workplace safety, that in no way is seeking to negate the reality of the situation in which we are running a facility where sometimes people get hurt and can get hurt badly, because we are providing care to the most acutely mentally ill individuals in Vermont. We are always focused on continual improvement. We have lots of processes in place to do that, and I'll kind of share some of those and have VPCH flesh some of those out. But also, absolutely, mistakes get made, and our commitment is always to learn from mistakes and our successes and focus on ways to improve. So we were here and wanted to talk about our workplace violence prevention program, which I think will answer a lot of your questions. And of course, we're happy to answer questions at the end. This is something that we have had since 2018 and that we do update every year. And so it goes through our commitment to workplace safety and the different things we have in place to help making sure we're always keeping an eye on that, to make sure that we're continually improving, and to make sure that we are including staff input in every step of the way. Sometimes we can't sometimes we have suggestions from staff that, while well-intentioned, we cannot implement for a variety of reasons, but our commitment is always to hear them and to think about ways that if we can't do exactly what they're suggesting, there are alternative ways that we could approach a problem. And I will send a link to the committee assistant so you can see our workplace safety program. It is posted online on our website, but I'll also send that link to you. So the document is really a program about how VPCH itself looks at workplace safety, which is, of course, one of the key components of the work we do. The document really starts on VPCH leadership commitment, which is to create an environment as safe as possible for staff, hospitalized individuals and visitors. Again, it doesn't mean that we can completely erase the risk of working with this population, but it does mean that our commitment is to always work towards improving safety and working towards creating an environment that's therapeutic and as safe for everyone as possible. One of the sections that we talk about is PROACT, which is, I think, as you heard about, is our de-escalation and response training. So PROACT stands for Professional Assault Crisis Training. It's taught at VPCH and River Valley. Every inpatient unit has some type of model. Not everyone uses PROACT. There are different ones, but PROACT is the one that we have used. It's a national model that's used by thousands of facilities across the country. And as you heard, employees are taught PROACT before coming on the unit, and then there are refreshers. Why do you use a tool like this? Because data shows that employees who have developed a systemic approach to intervention during incidents of potential assault are less likely to be injured than folks that do not. And so PROACT really does several things, right? It includes hands-on training, and early recognition and assessment of dangerousness. It talks about de-escalation skills, including crisis communication and techniques of evasion and escape. And it teaches hands-on training and how to remove yourself from a situation or how to safely handle a situation when there is an emergency and voluntary procedure. And I think Nicole and Grace, if you want to talk a little bit about what PROACT training looks like. And I know there was some testimony around maybe a change in how some training was given. And so if you want to talk about that too, that would be great.
Before you do that, I want to see if the committee has any questions of you.
And I'm not done. This is just where this was a break where I was going to ask them, and then there's lots more components to our program. This is just one part of it.
So what you're going to do is switch off every once in a while to somebody else?
Yes,
Okay.
I apologize. I should have made that clear. Yes.
Okay. Go ahead, Nicole.
I actually used to be a PROACT instructor, but since I no longer work on the units, I have put that aside. PROACT really focuses on looking at preventing assault, and the program is a 16-hour course, so 2 days where you look at how you can recognize escalation, how you can intervene before things become to the level of where someone may become assaultive. And that's the first 16 hours of the training. And then there is a 4-hour training that is specific just to restraint. So that's the base. And then every year, and this part I'm no longer involved in, but every year there's a 4-hour refresher training that focuses on keeping people's skills up and running. And I can also speak a little bit to the on-the-spot trainings that were happening, because that was part of Safety Council, which I've been a member of the Safety Council since its start in 2018, 2019, somewhere around there. And we really focused on listening to staff wanting more training, and the folks who are really passionate about doing this training did a phenomenal job in doing that training. Unfortunately, one of the techniques that they were doing was not vetted, and it included something that was against regulation. It involved using a tool that we can't just use a tool without it being specifically vetted by regulation. And so we had to scale back on that and look at a way to do it differently to make sure that we're meeting regulation and that staff are being taught things that they can actually do without causing any undue harm to patients or the hospital itself, making sure that we stay, within our regulatory guidelines.
Thank you, Nicole. And so that I think is a good point. So VPCH as a hospital, right? We are fairly heavily regulated. We're licensed both by, or we're licensed by VDH as a hospital. We are CMS certified and Joint Commission accredited, which are kind of national standards. And those are things we need to meet to continue to get Medicare and Medicaid funded. And then there's also Vermont law. And there's the Emergency and Voluntary Procedure Rule, which is an administrative rule that regulates and governs when we can use seclusion and restraint in the hospital. So those are all different layers of regulation. Some of those do look different. I think we heard about how it can look different in different states. It does look different in different states because states have some of their own requirements, right, or regulations. Vermont, when we created the Emergency and Voluntary Procedure Rule, it was specifically designed to be stricter than the requirements of CMS and Joint Commission. So we do have a rule that may look different than other states because of that. So that's kind of the PROACT training, that portion of our program. One of the other commitments in our workplace safety plan is event reporting. And I think you've had some questions around what are we doing to monitor this thing and the things that happen. And also that's a requirement of the new legislation. So we have what is known as event report. We have an event reporting policy, right? And so that is a key component of the continuous quality improvement we do at VPCH. And we have lots of different event forms that we have folks fill out and that we monitor. Employees are encouraged and supported in reporting all adverse events and near misses. We have 8 different types of forms that we have folks report on, that we follow up on, anywhere from medication management to those patient events. The report forms all include prompts for documentation of supervisor and quality department follow-up. We do have a whole quality department at VPCH. They organize, analyze, and maintain all of these reports. They're always viewing them. And then we do follow up based on kind of what's in the report and what we need to follow up on, including plans of correction, causal analysis, is root cause evaluation. So that was kind of one of your questions. When there's a serious event, is there an investigation that goes into it? And yes, we call those root cause analyses. Those are peer protected documents, right, under statute, because they're part of a hospital's ability to kind of take a deep dive into what happened and how we can improve. Both of those events that you heard about did have root cause analyses. The last one, the commissioner and I just met with the team yesterday and had some follow-up. So yes, absolutely, those things are happening, and those are the basis of changes that the hospitals make. I will also note that on top of all the internal documentation that VPCH does in terms of events, every emergency and voluntary procedure, when we use a seclusion or restraint, by administrative rule, also has to have special documentation we call a certificate of need. And that documentation also goes to DMH central office. So our quality team reviews each and every single emergency and voluntary procedure and follows up as necessary. That's not just for our hospital, it's every hospital across the state. In addition, Disability Rights Vermont, as the mental health care ombudsman, also receives those reports and can follow up if they have questions. So there are a lot of eyes on these, not just in the facility, but outside the facility. And certainly if there was a report made to licensing and protection or CMS or Joint Commission, they come in and they can review those documents as well. So there are a lot of eyes on what we're doing.
Okay.
So those are the reports and kind of how we follow up. Sorry, was there a question?
No, well, no, I was just going to say, okay, thank you very much. I think we've got a pretty good picture of all of the things that are going on up there to try to prevent what's happened. Now, what I would like to do is have Wendy talk about the reaction, what has happened. She runs the hospital. I'd like to find out what steps she's taken, because one of the things you said is every year, all of this information is reviewed and any changes are made. So I've got some questions for Wendy, if Wendy could come up.
Sure. And I just want to say before, there's a bunch of other parts to it, and I understand you don't want to go through them. One of the things, though, I do want to highlight, if we get to it after this, is the Safety Council, which Nicole mentioned, and that is a group that we've created. It's been around since 2018, and that really is where staff go and provide input to leadership around different issues they see as safety issues. So I do want to make sure that there's time for you to hear about some of the good things that are happening there. Nicole had a couple examples of when staff came to Safety Council with a concern and leadership was able to address those. So I just want to make sure you also hear on that,
Okay.
because I think that also gets to some of your questions.
Oh, okay, thank you. Wendy?
Thank you.
Okay, Wendy, what my understanding from what we've just heard is there's all kinds of training, there's all kinds of review. Everybody is trying to work together to do certain things. My first question is it unusual for the hospital to have as many people injured as have been injured over the last year?
I can't speak to looking at it as a whole. I can't speculate to it as a whole, but looking at individual instances, after a situation happens, any event reporting goes to the nursing supervisor, who passes it on to a particular event reporting group. Everything gets to quality as well as myself. We review these daily, but in weekly meetings, we come together, whether it's our EIP committee that meets every Wednesday, to have a conversation about the past EIPs, what's going on particularly with that individual, treatment, is there some anything else that's possibly needed? Are we seeing any trends? And then it also goes to our executive leadership committee meeting that happens every Thursday, where our quality department submits a Power BI dashboard looking at all of the events, whether it's employee events, the EIPs, and looking at it and seeing if we're seeing some type of trend, what needs to happen. We will then possibly do a deep dive regarding a particular hospitalized individual. So those are the things that we look at. We go into rounds. After a big situation, I will hold a debrief with the entire hospital, because we really focus on shared governance here at VPCH, where everyone has a voice, and to make sure that everyone is being heard, to ensure what went well in a situation, what did not go well in a situation, hear that from staff. And then it really is tasked on myself and the leadership team to really do a deep dive in completing a root cause analysis to look at all of these different components, and then what improvements, making sure that we are adhering to all the laws and the regulations, but to be able to make changes, bringing back to the staff and communicating with them in real time, making what changes we're making. We pull in the Safety Council, any type of suggestion when it comes to whether it's additional training regarding PROACT or the use of any other tools, has to be vetted through the Safety Council. How we look at our workplace violence plan is really and truly, everything starts at the Safety Council, and which is staff run. And they look at it they look at the workplace violence plan, they look at staff suggestions. They will then, whether they test it out, they do the research, and then they make recommendations to myself and the leadership team. And then we take their considerations and we will then go back and forth to make those changes.
Okay, that's wonderful. Can you tell the committee what the most significant change you've made in the last couple of months based on, other than having a patient removed from the hospital and transferred some other place? What have you done, a significant thing that you've done to avoid what has been happening up there in terms of employees being injured?
I do just want to clarify that we didn't have any patient removed.
I'm not saying you did. I said, other than having a patient removed.
Right. I just want to say we only discharge folks when they're clinically able to discharge. So I just wanted to clarify that I know there was some testimony around an individual who was having some EIPs was discharged. That wasn't because of that. It was, people discharge when they're ready to be discharged. I just want to make it clear that we wouldn't, if someone was really struggling with their mental illness, we wouldn't just discharge them. We would work to treat them. And then they may be discharged. I just want to clarify that. I also did, before when he goes, I just did get some clarification from quality on there were 7 ED visits in 2025. So I know that was a number you had a question around. So there were 7 folks that went to the emergency department.
How many?
7.
7.
Yes.
Over the last year?
In 2025.
Okay. Oh, and this year. Okay. All right. Would you answer that question, please?
Could you do me a favor? Could you repeat your question?
What is the most significant or a significant thing that you've changed in 2025 based on incidents that happened?
The one thing that we did change, and this will be continuous moving forward, is how we interact with staff. One of the things that we heard from staff is that they really wanted to make sure that we were listening to them and making sure that leadership was attending rounds and being in person with everyone. So that was one change we made. The other change is how we do staff meetings. Regarding the debriefs, the debrief meetings that we have when any incident happens have really been very enlightening. It really great communication. And so we've changed up how we have done, how we will continue to do staff meeting to really get input instead of having it leadership run, having it hospital run. And so really getting input before the meeting from staff on the topics that they would like to be heard. The other thing that we are continuing to make changes on is every year we have a culture of safety survey that is completed at the hospital. And we have created an EPIC committee, which Nicole could speak more on. And we are, they're in the process of rolling out various changes that we are in the process of making regarding the identified improvements that the staff would like to see based on that survey. So those are some of the changes regarding when staff come and approach us with various things that they would like to see regarding additional training or possibly changing up PROACT. We're in the process right now of looking at PROACT. I've asked the Safety Council, gave them a list of various types of programs that have been, that are evidence-based, that hospitals across the country have used, to ask them to go and please vet these. One of the hospital employees approached me regarding another type of program, and I asked him to please do a presentation for the Safety Council, so I could get their recommendations. So that is one thing. Regarding the acuity team, We are in the process of contacting other hospitals to determine what does that look like for them? How do they have any policies regarding that, and getting more information so that we could see if that is something that we can implement at VPCH, how would we implement it? And then bring that back to Safety Council and really and truly partner with them. So staff know that they could always go to Safety Council. Safety Council has little suggestion boxes throughout the hospital where staff could go and talk about their suggestions, any concerns, and then Safety Council vets everything and then brings that to executive leadership. Nicole, our director of operations, our chief executive, nurse executive also sit on that. It is not, they don't run the committee because it's staff run, but they are part of it. And we get updates weekly regarding Safety Council.
That's wonderful to hear. Nicole, do you want to chime in now?
Sure. What would you like me to address? The Safety Council?
Yeah, right.
So the Safety Council started in 2018 or 2019. And I've always been passionate about staff safety. I used to work as a mental health specialist on the units. That was how I started at the hospital. I don't want to age myself, but 16 years ago. And that is when I really became passionate on, because your coworkers are like your family here, of making sure that staff are have the tools that they need to be as safe as possible. So I joined the Safety Council with that intention. And at the time, I was the staffing office manager when the Safety Council started. So some of the things that we have done all come from direct staff feedback, including from the members on the council that are direct care workforce. And we always make sure that we have seats that are specifically held for the direct care workforce because their voice is really the most important when it comes to safety. So some incentives that we've done is, like updated restricted items. Floor staff were concerned about the golf pencils that patients could use, and we found a product that was a flexible one, which would less likely cause harm if someone were to try to weaponize it. Another thing that we have done is update the precaution monitoring form. And what that is the form that staff use to round on patients. So every 15 or 30 minutes, a patient behavior is documented. And we made that form more precise and clinically informed tool to help staff identify early signs of escalation and allowing them to intervene proactively and begin de-escalation efforts before the safety risks arise. Another initiative that we did, or what we do consistently, is use what's called a safer risk matrix. A tool that comes from the Joint Commission, and it's a nice tool that really helps you categorize different risk levels and kind of give you some framework on how to intervene. But in that process, using the safer risk matrix, it involves canvassing and asking staff opinions. So we go around to different staff members and who would be involved with whatever the item is being assessed and get their direct feedback on what they believe the risk level to be and what are some ways that we could mitigate the risk. So we're always looking at identifying risks and how we can help mitigate the risks that also achieve the balance, which is challenging, of patient autonomy and staff safety. So there is a balance that we always look to achieve.
Thank you. We have a, excuse me, we have a question from the committee.
It sounds like you have have like a high tolerance in this setting for violence because the patients are so acute and you're doing everything you can to mitigate the risk of the violence. I'm wondering if there's a point, because earlier it was said that you don't discharge people because of their behavior. You can't. Like when I was an intern at Smith 3, I think it's now called Shep 6 at UVM, I remember when people got really bad, we would send them to at the time, the state hospital. So but that was like the end of the road, you know, like the most acute place at that time. And it sounds like it still is. So when someone's becoming unmanageable at your hospital, is there anywhere else they can go? Or do you just have to maintain them and try to mitigate risk until they stabilize? That's my first question. And the second one is when a person who is a patient has caused harm that could be considered criminal, do they ever get charged with crimes? Do they and if not, how are they held accountable once they stabilize, or is it just kind of forgotten?
So I'll take a stab at those first, and then I can let VPCH weigh in. I want to be clear that we have a zero tolerance for workplace violence, and we also acknowledge that when you are dealing with folks that are acutely mentally ill, there is a chance of violence, right? So those you can have both of those things, and we work really hard to mitigate it, but of course we don't accept it. I think the emergency and voluntary procedure rule is really clear about when we can put someone in seclusion or restraint, right? When we can put hands on, and there has to be an imminent risk of serious bodily harm. And so, no, you don't have to wait until violence happens, but you can't just seclude or restrain someone, right? You have to make that clinical assessment that they are getting to the point where that is necessary. And sometimes that comes out of the blue, right? Sometimes there is no way to anticipate that. Other times we are kind of proactively thinking about someone who's been acute, maybe what are the signs to look out for? What are things you do to kind of be prepared to try to ward off that? So I just want to make it clear that just because we acknowledge that there is some level of that, it doesn't mean it's ever acceptable. In terms of So there's a difference between someone acting in a criminogenic manner, which is when the criminal justice system would step in, and someone who's acutely mentally ill and having behaviors related to that, right? So we don't punish people for having a mental illness, but certainly if someone is acting in a criminogenic way, then that is when the criminal justice system comes in. When you are in our hospital, the determination has already been made that you are at such a high level of mental health need that you're there to get that is different than an emergency department, right? Like you don't come into our hospital until those determinations have already been made. We do have, if staff are assaulted, and I apologize, I didn't get a chance to review this, but it's in our policy, but staff do get a packet of information, and included in that is an affidavit. So if they had wanted on their own to say, file an affidavit and ask the police to file charges, that's certainly something that they can do. I will say that, someone who is in our hospital because they've already been found to need involuntary care, most likely, if the state police or locals were attempting to file charges against them, probably the first thing the defense attorney would do is ask for a competency or sanity evaluation, right? And so if you're not competent, or you're not sane at the time of the offense, you can't be prosecuted for that. So I think there's a difference between people acting in a criminogenic way and people who are experiencing acute mental illness and having behaviors related to that.
I understand that, but I have a follow-up question.
Okay.
It is important. I think the point I was making wasn't necessarily, I appreciate you outlining the policy, but it wasn't about punishing someone. It was about accountability and more in line with like how it also involves the victim because a person who got harmed could go and submit an affidavit, but they may not want to punish the person either. Like, are there any restorative practices being used to try to repair harm? When, like, for example, I had a friend who had a psychotic illness and they don't remember half of what happened, and we're still little by little. I tell them things when they ask, and then they go into like this deep mourning over the harm they caused, and there's no way that they can even reach out to the people they harmed because those people want nothing to do with them anymore, and so they're living with this guilt for things they did that they don't even remember. And then there are people who want to make peace with them and don't know how, and we're navigating this. But like in that setting, if harm occurs, and then is there any way for the staff and the patients to reconcile or have some kind of restoration once there's competency again and a person becomes aware of the harm they caused?
Grace, I don't know if that's something you want to touch on.
Hi, sure. So after incidents where harm has been caused, we'll usually engage in a staff debrief process. We also do offer like one-to-one supervision with our psychology department or our education department. And then usually because the patient, the hospitalized individual continues to be here, we will offer the victim of the assault, the employee, like time off of the unit, but then slowly reintegrate them and allow them to like rebuild that rapport with the patient. And often through the patient debrief process and the ongoing staff debrief process, we can reinitiate like a good rapport between patient and staff.
Okay. Grace, you haven't had a chance to talk very much. I'd like to give you 2 or 3 minutes now, and then we're going to have to close this. Can you just talk about, there's been 7 people that have been sent to the emergency room in 2025, and others have been sent before that. All of the training and everything that you're talking about, it all sounds wonderful. And it seems from what you're saying that you're trying to keep up with things by having the staff involved in decision-making and changing things. Can you just give us some idea? You're the chief nursing executive, correct? So you're working interim.
Yeah.
Are you a permanent employee?
No, I've actually been with the state hospital system for 18 years. So I started as an LPN.
Okay. So you've been around. You're not a traveling nurse. Yeah. Okay. So can you just talk to us about the improvements that have been made just in 25 and be specific if you can, because people are still getting hurt and hurt badly. And I know you don't want that to happen. Tell us what you've done in 25 to help this situation.
Sure. So one thing I think we've really been focused on in our nursing department is really empowering our charge nurses and our nurse supervisors who provide 24/7 coverage that to look at the staffing needs for any like individual shift or time period of acuity, and then adjust those staffing numbers as needed, which did ultimately help in our recent bout of high acuity. So that's been our focus really in 2025, and particularly in the last few months. During periods of low acuity, really focusing on like letting staff rest, like maybe not utilizing the extra staff that we might utilize during periods of high acuity, so that we're trying to also avoid burnout. But when the need is there, like really empowering the people that do the direct care to utilize extra staff if needed.
And how does that, we heard testimony that when you take people from other places, it causes a problem in an area. Are you understaffed up there?
I've only ever worked for this system, so the staffing numbers I know are what I know from here. I know that we work with, many travel staff who join us, who come from other hospitals that are, pleasantly surprised by the number of staff that we have in our direct care units. Just because they feel safe with those numbers. They're impressed by the amount of staff that we have available. And they say that that's just not an option anywhere they've ever been. And I feel like from my days as working in the direct care that we have an adequate number of staff. We just have to really work with our direct care staff to utilize those numbers appropriately.
Okay, thank you. Now, any other questions from the committee? Go ahead.
Is there any legislation that we should be considering putting forward that would help in the protection of your staff and employees there at BPCH?
The department currently does not have any legislative asks related to this.
Okay, thank you.
So we just passed, I think it's H 259 about workplace violence and having a plan or developing a plan in hospitals. Does that apply to you, and is that work you will be taking on?
Yes, so I'm sorry if I wasn't clear about that when I started. Yes, it does. We are licensed as a hospital, and that's why I was actually going through the plan, because that is work we had already done. And so I wanted to show you guys all of the work that we had done, because we do have a program already in place. We've had it since 2018. And so that's why, I apologize again if that wasn't clear. That's why I was kind of going through the components of it, the components kind of matching the things that you had asked for in that legislation. That was our understanding, apologies, of what you wanted to hear from us today. So I'm happy to review that more.
I didn't get that connection, so sorry.
Nope.
Would we see your plan?
Absolutely. We will get that sent to your legislative assistant so you can review it. It's posted on our website too, but we'll send you the direct link.
Thank you.
Thank you very much. One more question.
Yes.
Daisy. Sorry.
Thank you so much for coming in, Karen, and all of the others that spoke. I apologize that I'm at home sick and can't be there with you. I guess my comment is, regarding the policies, I noticed there was a question asked earlier, and, Karen, you spoke to, you have a policy of, a zero tolerance toward violence, and jumped right in to say that. And it was really, surprising to me that, some folks who are in leadership there at the hospital weren't able to speak to that directly themselves. And maybe they are, but are capable of that, but it's telling to me who's not in this room speaking to this, and that the Department of Mental Health sent their attorney. And now I have immense respect for Karen. We've worked together for years in various capacities. But my vision is that someday we see people who are providing direct service, who are fully aware of the policies and their rights for safety in the workplace. And I guess that's just my takeaway from all of this, is that we have a better transfer of Karen's knowledge and expertise to people who are actually providing the work, and that the legislature is there to back them up with the mechanisms for accountability.
Thanks, Daisy. If I could just, so they all could speak very eloquently to this. I think the reason I offered to kind of help is, one, I've been around a really long time. So I was there when a lot of the folks in leadership now at the hospital were not, when we developed this plan, but also I testify a lot and I'm much more comfortable with it. So they were here and can answer any of your questions. We also just wanted to make them feel comfortable their first time testifying and kind of let them add in as they are, without kind of making them their first time testifying take the lead in doing this. But certainly that should be on no indication of their lack of knowledge on this or their inability to speak to it. It was simply, this is something I do a lot, and so I offer to kind of help guide the testimony to make it more comfortable for everyone. But certainly it's in no way means that they don't fully support this or this is the work they do every day. I'm just kind of helping in terms of of testimony, and I apologize if I have made it seem that way, because that certainly wasn't my intention.
No. It's nothing to apologize for. I'm just making the point that, I hope that the legislature, as well as the administration, is supporting staff at all levels to be aware of all of their rights and the mechanisms for accountability and exercising those rights for working in a safe place. And I know I heard that there's a suggestion box, there are various policies written, but actually being able to stay aware of those, are there enough trainings? Is there enough resources that we're making available to staff so that they're continually reminded of what those mechanisms are? That's the kind of stuff that we need to be hearing.
Thank you, Daisy. We have one more question, and then we're gonna have to close it.
Okay, we really do have to go.
Yeah.
I'm just curious, you said that VPCH is a level 1 facility, and does that apply also to Brattleboro and Rutland?
Yes, so they both have units, but their whole facility is not
Okay.
level 1, but they both have level 1 units, yes.
And what are their incidents for this past year? Do you have any idea?
I do not have that data in front of me. It's probably comparable. I'll say acuity comes and goes, right? And so we all tend to deal with acuity at different points.
It would be interesting to look at those other facilities to see how VPCH compares to those other facilities. And if the numbers are down in those other facilities, maybe you should be taking a look at what those other facilities are doing.
Sure. Yeah, we can follow.
And enact them into your own facility.
Okay. Thank you very much for all the statements. Thank you very much for all the time you spent with us. I think as we go through the implementation of 259, you people will probably be back in helping us improve on the situation that we're in. Thank you very much, and I'm going to turn this meeting over to the chair.
Thank you, Mr. Vice Chair,
You're welcome.
for leading this meeting for me. We need to turn to 266 again, just to let you know that we identified a little issue with the effective dates, and to address the hospital's concerns, I had Jen just sort of draft. It's not a new draft, it's like adding duplicative language of what we already straw polled yesterday. So we just need to re-straw poll, and then this will be what we'll have put in the House calendar for tomorrow.
Good evening, Jen Carby, Office of Legislative Counsel. So yes, this is H266. We're actually looking at the amendment as an amendment today. And we're looking at some new language that is not new to the draft, but it is new to the place where it is. And this is reflecting some of the language for what is becoming Section 5. It was Section B, and what we looked at, it's the 2025 language. And there was some concerns that that there might have been pieces that are in the Section 4 language that should also be present in the Section 5 language. So I will put this up on the screen so you can look at it, and you'll, I think, pretty quickly see where we are. So as you recall, we had talked about it, but you hadn't actually seen it as an amendment yet. So I've got everyone who was here and was in favor of being on the amendment listed. We are striking out sections 4 through 7, which is the white bagging sections and the effective date, and putting in new sections. So section 4, we had looked at, this is the 120% ASP language. But as you may recall, in this language, there was a subsection B that talks about the purpose being to reduce healthcare costs, and no balance billing, no increasing charges for other items to offset the revenue reduction, and then allowing a hospital to demonstrate to the board in its budget submissions that the price cap is having a negative impact on access, quality, or sustainability, and asking for a commercial rate increase for one or more service lines, such as primary care, and the board to consider those. So in section 5, which is the 2025 version, which is a little bit different because it's 130% ASP for 2025. I have simply put that B1 and 2 in this section as well. So again, saying the purpose is to reduce healthcare costs, no balance billing. The hospital cannot increase charges for other items to offset the revenue reduction, and the hospital can demonstrate a negative impact on access, quality, or sustainability, and the board can consider increasing reimbursement rates for one or more service lines. So there was some concern that without having this language in section 5, there was not the prohibition on balance billing and increasing other prices for 2025, but also not the avenue for the hospitals to seek rate increase for other service lines as a result. And so putting this language in here has this take effect on July 1st, 2025, as opposed to the other piece that starts January 1st, 26. And that's it.
So we're taking same language, we're just adding it,
Copy and paste.
make sure, and that starts a month from now. All right, any questions? Yes.
Is it too late to add me?
Not
For voting on it again?
Oh, yeah.
It's not.
I would like to
Great.
be added. I watched yesterday, even though I missed being here, and I
No, this has not been submitted for the
Okay.
calendar,
I'd
so
like to be added if
it is
possible.
timely. I will add you alphabetically.
Should we do a straw poll on whether or not the committee wants to add Brian to it? I would.
Be off the island, I'll just-
Down over here. Okay, so if there's not any questions about, and everybody understands why we did that to meet that concern, then I will like to, all in favor of amending it as again amended.
Brian gives
And 1100. Well, that's great. I'm glad we did this because it was in, yeah, Daisy put her hand up.
It's okay for hearing.
Yep.
Because now
So,
we do have everyone.
yeah. So thank you, everyone. That was it.
That was it. We kept you
I'm sorry that this took up our break time. And we are turning to Matthew Sutter from the Green Mountain Care Board. Speaking of hospital budget submissions, we have spent an enormous amount of time this year talking about the process that the Green Mountain Care Board uses and all of, their various authorities. And I thought it would be a great idea to get a tutorial into the enigma of what hospital budget review actually is. So thank you for joining us.
Hey, thanks for having me. I'm excited for the opportunity to explain the work we do. Thought about putting a presentation together, and then I thought this might be better to just kind of discuss the process, and we can, I don't want to call it informal because it's legislative testimony, but maybe just feel free to stop me at any time. I'm going to run through the timeline that I shared with everybody this morning, and then please interrupt me if you have any questions. I'm just going to speak extemporaneously about our process. So the budget review process basically takes up a full year. Basically, so it's almost on a rolling basis because once we start looking at actuals, it kind of bleeds over to the next year. But basically, at the end of about the holiday season, we start meeting internally with interested parties to kind of just debrief. Maybe we call it a little bit of a postmortem of last year's process and just kind of really figure out the things that worked well, what didn't work well, process-related issues mostly, and talk about ways that we could maybe improve the process. And so we just kind of get that kind of level set with everybody, kind of see where we all are on the same page. We board members figure out what they liked about our review process, things that we could improve, recommendations for next year we might get. And that kind of leads into the calendar year. And starting in January, we really internally, my team, we start meeting and discussing, what hospital guidance will look like for the coming year. And maybe at this point, maybe I need to stop and kind of explain what guidance is for the hospital budget review process. So annually, the board approves guidance for the hospital for budget reviews. And what guidance establishes are some benchmark, among other things, some benchmarks that the board establishes for hospitals. So we ask for them to come in under, or if they cannot justify why they can't. So this process, we basically look at what we did last year. Historically, what we've done is in years past, we basically regulated off of change in their charge master and net patient revenue. So revenue cap and charge master increases. Lately, we in the last couple of years, we've been looking more at price. So there's a lot of nuance with hospital budgets, hospital finances, I'm sure you're all aware. And the charge master, it is what it is. So it's increased. So how I'm afraid. So you can increase the charge master, let's say 5%, right? And the way a lot of hospital contracts will work with commercial insurers is you'll have a deduction off of the charge master is how they kind of agreed with the contract. So prior regulation kind of focused at charge master. Hospitals would then go and negotiate increases, ensuring that they're under the cap. But what we really came to find out recently was the importance of focusing specifically on pricing. More specifically, given our current situation, states on commercial insurance prices, because we saw and we heard that there was a lot of variation in how hospitals are applying rate increases and how they're affecting commercial insurers. So we really focused more or put our attention more towards the commercial side of pricing and trying to understand how that's working. I will say this year, we also added an operating expense benchmark that hospitals are supposed to come in under. And what I was hoping for with that is that we would capture sort of, I would do this, and I'm sorry to confuse it, but I think of it like budgets as sort of an equation, right? So revenue equals expenses plus their margins. You can just think of it that way. And the way we've been regulating is that NPR cap and lately the commercial price increases. So really, that's the revenue side. We've been touching the prices and then through the NPR cap, kind of getting at utilization also. And then hoping by controlling that, hospitals will reduce expenses or have to control expenses. And frankly, we've seen, especially since the pandemic, that not have. It varies wildly between hospitals, but I'll give you an example. UVM is over, on a compounding basis, over 9% expense increases year over year since the pandemic started, which is massive. It's almost, I want to say like double what we were seeing from some of the mid-sized hospitals and certainly higher than what the critical access hospitals have been doing. So we really wanted to add an expense benchmark this year to really ensure that we're capturing both sides of that. So basically, when we're developing we meet internally, we start developing, the coherent hospital budget guidance. We look at what we did last year, we iterate off of that, we talk about improvements we can make. And then then we come up with some benchmarks we think the system can afford, the hospitals will maintain hospital solvency. And that can be tricky because, we have 14 very different hospitals, very different sizes, and there is not a one size fits all, press a button, here's a good budget, or here's for all of them. So there's always nuance and there's always caveats, and all the submissions are reviewed independently, but for purposes of developing guidance, we really have to take kind of a system-wide look. So before we publicly reveal, show guidance to the board, or draft guidance, we meet with VAHS, we meet with Healthcare Advocate. I believe we also met with some hospitals this year. But there's I don't know if it's statutory or rule-based, but there's a requirement that we meet with VAHS to kind of, and the Healthcare Advocate to kind of explain the benchmarks that we're looking at for this year. So we met with them in mid-February, and then we presented hospital budget guidance to the board and the public on February 19th. At that time, it opens it up for public comment. This year, because the operating expense benchmark was new, we explicitly asked for public comment on it, knowing that there might be some nuances with, critical access hospitals are reimbursed on cost, right? So if we're setting an operating expense cap or effectively a cap, maybe there's things that we need to consider, differences for critical access. We did explicitly ask for public comment around the OpEx benchmark and received very little. But we did this year also add an extra meeting. So once we once we release the draft version of guidance to the public, then we have a couple other meetings there. So there'll be revisions, we'll take public comment, feedback from the board, stakeholders, staff will internally discuss them. And if so it's a long document. There might be typos in there. There's all kinds of revisions it can make. So then we come back in mid-March and present the revised guidance, kind of explain changes we may have made. We have a change log now that we post publicly. So everyone's aware of anything that we made and provided basically the same presentation again to the board and making sure the public's aware of at all stages of development where we are. Public comment period still open. A couple weeks more go by, then we have the final version of guidance. We integrate any other revisions and present that to the board for voting. They need to approve hospital budget guidance by the end of March. I believe, I'm getting my rules and statute mixed up. I apologize, but I believe that's a statutory requirement. So board voted and approved hospital budget guidance at the end of March. And that basically starts the process. Hospitals then develop their budgets and submit to us by July 1. Now, hospital budget guidance outlines what they need to submit to us. It's pretty explicit. We outline, they need to touch on these materials in their narrative, in addition to justifying their budget. So they can submit essentially whatever they need to, and we ask them to submit anything they need to justify their budget. There are some specific questions or the public or staff feels that, should be answered by all hospitals that are included in guidance, and ask that they respond to them in their narrative. And guidance also lays out the other filings that they have to provide us, a lot of which are, through our database Adaptive, which is where they submit like basic financial tables, income statements, balance sheets, that kind of stuff. We also have a pretty detailed supplemental workbook that hospitals fill out. And so in that, we ask for, I try to keep it fairly consistent, but, year to year, the environment changes and we might have different things that we're interested in. So this year we have explicit breakout of 340B revenues and expenses, including that supplemental workbook. We feel it's important that we get a better understanding, a more thorough understanding of pharmaceuticals. It's becoming very clear. Because there are sustainability issues in the system. Everyone knows this. We're asking for contingency planning. If you are submitting possible to submit a budget to us that's not compliant with our budget guidance, what service line adjustments are you going to make, or would you have to make in order to submit a compliant budget? We're asking for, specifically for the health network, because of the issues around money being sent to New York or Vermont hospitals subsidizing New York hospitals. We're asking that they submit a consolidating financial tables for us with the Vermont hospitals and then the total UVM health network, which we can get through the audited financial statements, but those are several months later. So for the budget review process this year, we'll have a better idea of network level finances, similar to how we review them with the audits. So let me pause there and see if there are any questions. I've been kind of rambling and I want to make sure I'm kind of
1,000 questions.
Yeah.
Does the state auditor have authority to audit any of the hospitals?
That is a great question. I don't know the answer to, but let me absolutely get back to you on that.
I'm wondering if you contracted with, I don't know if you can. I don't know.
I think I can answer that only because we had testimony recently, because remember there was a part of one of the bills about allowing the state auditor.
Mhm.
And I think because hospitals are private entities, the state auditor can only audit state funded things.
So they can only.
Yeah. Yeah, the state auditor can't go into a private
I think
business.
we'll have to look into it. There is some authority for the auditor because we use public funds.
Yeah.
So I want to look into
I knew it was squishy is, I think what I was.
What I can say is that the care board does have a lot of discretion in the what we can ask for on an ongoing basis throughout the year as they submit, year-to-date actuals, and if we have questions, we can ask them for additional materials. So if there was, I think if the auditor was interested in something, I think we could probably, it was relevant to our reviews, I think we could probably
Publicly post all of it.
Yes, yeah.
So the auditor.
Yeah.
Go online.
Yeah.
Leslie.
So I'm thinking about Springfield Hospital in my area. And one of the things we heard the other day was that the reason Springfield hospitals sustained was they weren't paying bills. So that when they submitted their budget to you, there was no way that you could know what was actually going on there internally. So that worried me.
Yeah.
And I'm wondering what mechanisms are there to think about? I mean, would that be material misrepresentation? Where does
So-
that fit in? So I'm just trying to understand what levers you have.
So I'm not an attorney, so I won't characterize this material.
Well, I'm not an attorney either, so.
Yeah, they always get nervous and I feel like
I'm
non-attorneys
not
start
really-
using words like that.
I am not an attorney.
But yeah, but that's a very good question, right? So we get these budgets from hospitals and a lot of it has to be taken, we're a small team. I've got 4 people on our health system finance team. So we're not auditing their submission. We just frankly don't have the capacity for it. But what we do is sort of look at it and see what questions arise. And so to your point, Springfield, we're now collecting monthly actuals from hospitals in the same format that they submit their budgets. In the past, how it's been, they've submitted quarterly actuals in sort of a stripped down like summary format. We're not doing that anymore. I need to know monthly what is going on with these hospitals in the same way, in the same account structure that we get their budgets, so that we can do real year-to-date budget actual comparisons and know what's coming in. I don't know the specifics around what Springfield.
Yeah, but do you think that would detect something? No, how could it? And that's what's confusing me and worrying me. It's like, how could you know that that was being done by just seeing a budget submission?
And yeah, there's just the budget submission on its own. They would have no way. We'd have to look at it in conjunction with their reporting, historical records of reporting. And last year, we really did start taking a look at how well they budgeted, how close hospitals are getting to their budget and their actuals. Just to know, like, is how much when they submitted, how is this real? I guess.
Yeah, that is a good question. And how do you know? And that's what's worrying me, I guess.
Yeah.
How do we know? Well, some of it's faith, which didn't work so far. So I'm concerned.
And if I could just add, so some of the more detailed reporting we're getting. I'll mention it's on our website if anyone wants to take a look. But we have in the supplemental workbook, we have something we're calling the rate decomposition sheet, and hospitals need to break down their submission and show us how the rate's being applied, how much utilization is affecting it, payer mix is affecting it, and it all builds out to their total net patient revenue. So again, it won't on its own tell us if the budget submission is accurate or valid, but it's another source we can look at and say this just doesn't make sense. So yeah, that's a lot of what my team does in July and August, and then ask follow-up.
Yeah.
I have a question, just because I feel like I spend an enormous amount of time on the Green Mountain Care Board's website, in case you think nobody's looking at it. I am. And just trying to grasp the information that I'm getting from when hospitals submit their budgets. And all the, there's basically balance sheets and P&Ls and all of that, but trying to read them. And maybe you could help me a little bit, because this has come up with H266 that we are, that, we're hearing, we just voted on our amendment to it, and it's on the floor tomorrow. Do the hospitals give you detailed information about, here's how much I'm just thinking about a P&L. Here's our expenditure for outpatient drugs, pharmaceuticals. Here's the revenue from those. And more specifically, I'm actually thinking about it at the network level, because we have multiple hospitals in 2 different networks. And I did ask the health network, UVM Health Network, the other day about, so if things, supplies, drugs are being purchased at the network level, how is that accounted for in the individual hospitals' budgets? Because it's the individual hospitals that are collecting the revenue from it. And where does it go from there?
Yeah, they should be showing up in the individual hospital budget. I think that's, but I would need to get back to a more detailed answer. I will say reporting has been our account structure has been a challenge. Right now, we basically the hospitals can report on like a whole list of things. Most of it rolls up to what we consider like other operating expenses or other operating revenue. It's a huge chunk of money. So right now, if I was going to do like an inter-hospital comparison of like, hey, how much has salary and benefits increased at Rutland versus SCMC? I can do that. We have pretty good accounting code for salaries. What I can't tell you is med surg supplies, how much they've grown at hospital X versus hospital Y. It's all, the only level that they're like consistently report on is that rolled up other operating revenue line. Some hospitals will report on it, but it's not done in I wouldn't say a consistent manner between all of them in a way that we can really make system-wide inferences from. So one of the things I would really like to do in the coming year, and we're starting on, is to get some contract help to really improve our reporting manual and make sure that we're asking for expenses and revenues at a more detailed level, but at a detailed level that hospitals can report on consistently. It does us no good to just, I can tell them to report on whatever I want, but if they can't, or it's not consistent between the hospitals, we're kind of back to where we are. We're kind of making challenging system-wide inference about non-salary related expenses.
Leslie.
So I come from the southern part of the state and have followed 3 hospitals down there. And I hear, unfortunately, a lot about how onerous the process is and the demand that's expected from the Remand Care Board to the hospitals. And I know 126 is trying to standardize the reporting that you're asking for, which is great. Love that. Have you ever thought about an estimate of how much time that you would be a reasonable, I don't know the right, how much time do you think it would actually take to do the work that you're asking for?
That's a good, I don't have an estimate. It's something that I'm at least personally very conscious of. I really don't, we're a regulator, we need to regulate, but I don't want onerous regulation. I don't want, and frankly, in my opinion here, I mean, I think I'll just give you an example. Grace Cottage probably doesn't need the same level of scrutiny that UVM does. Just we have limited resources. One of them had a bigger impact on the system. And so I think it probably is we have the same reporting requirements for all of the hospitals, a couple exceptions. UVM is the only one that's going to be reporting on those consolidating network things. But yeah, I think some of the reporting requirements probably for a Grace Cottage or some of the critical access hospitals, it's more challenging for them. They're going to have their CFO doing a lot of this work, whereas the larger hospitals are going to have teams of dozens of people working on their budget. So I do want to be conscious of it. And
How can we help that? I mean, going forward, just to think about that as, because we want we need it. So how do we balance?
What I would like to say, in a perfect world, we would be able to exempt certain hospitals from, I feel like, the review. If they meet, obviously if they meet certain requirements, right? So we have benchmarks we establish. I think statute does outline ways that we can exempt certain hospitals if they meet requirements. I don't think this is the year to do it, frankly. But yeah, that's.
Do you think that might be something that you could come back with for next year's guidance?
Recommendations? I would love to.
Yeah,
that would be something that we're all like just ambiently thinking about all the time. But or something that we kick around is our operating expense benchmark, right? Different hospitals have had different expense growth trends over the last, forever. Does it make sense to have the same benchmark for all the hospitals? Well, obviously, when we review all the submissions independently or individually, so we can treat nuances or there can be caveats with it. But in producing guidance, would it make sense in guidance for us to establish, different thresholds based on historical performance in different categories? I'm very open to that, but it'll take consideration. I don't want to do it.
I think it makes total sense not to do it this year, so we have a baseline across everything but the same, and then maybe next year perhaps think about what would make sense across the system. So just thinking about that.
Does every hospital get the same budget guidance? I mean, there was.
Yes.
Fast looking at it,
Is
it's
that
like something that should be changed.
Well, that's what we're.
I think
Yeah, so I don't know about when we say guidance, I think sometimes we talk about the larger document or just benchmarks. I think when we're thinking about benchmarks exclusively, they all have the same benchmarks this year. That's sort of one of the things that we've been playing around with, thinking about is that, what it would look like to have a sort of dynamic or different benchmarks depending on historical performance. Yeah.
I just, I think about if a certain hospital is really struggling and, is in the red, their budget in order for the next year is going to factor in, okay, you're in trouble, you need to build up your reserves, we're going to give you, this much more, or allow you to have this much more revenue. And then so that's sort of a one-time or two-time event. But if we're just putting out budget guidance that says everybody 3.5%, then you're building growth on previous larger orders that were meant to be a correction rather than a sustainable ongoing forward.
Yeah, I think, and I hope this isn't, I'm not missing your point, but I'm hoping the operating expense benchmark this year kind of helps with some of that. If I could give you an example, we set it at 3% this year, but the way our guidance works, it's relative to last year's approved budget. So, let's say, and we are seeing this with a lot of hospitals, they're exceeding the approved budgets. So just hypothetically, if our OpEx benchmark is 3% and the hospital's already running at 5% over their budget, they're going to experience that as a cut. So I forgot where I was going with that, but
Yeah, is that when you're building upon last year's or the year before's, you're just building on either the additional need or the overages. And 3.5% is completely different from Grace Cottage to even Central Vermont. Is in Grace Cottage to almost all others. We should do a field trip to Grace Cottage one day. I've never been there.
I would like to do that.
I would like to do that.
When the primary care, they're building a whole new primary care building. And that's their superpower, which is fantastic.
Nice coffee. Go to coffee. Yeah. Let's do a whole road trip, a hospital road trip. Devin, can you line that up all in one day?
Someone can get hurt in each region and we can see how.
Oh, exactly. Any other questions? Matthew? I think it's a fascinating process, and 4 people.
that's more than last year. So,
So I didn't think I had a question, but I just thought of it, and I'm not suggesting to put anyone out of work, but do you see a way that technological advances might help in budgeting of complex systems like a hospital or the healthcare system of Vermont? I know that the National Conference of State Legislatures has sent me some research on how government is beginning to use artificial intelligence technology to not make the final decision, but to inform the analysis. Then humans like us or you view it. Are you aware of anything that might help you?
I'm not, but just thinking out loud, this will probably get me in trouble. I'm sure it'll be useful, right? But really, really time intensive stuff of going in and looking at individual line level utilization assumption. I'm sure language models help with improving that. I would say technologically, it's we're a small team. I'm leveraging technology really hard this year to try to improve our reporting. So everything's basically being done in Excel, and we're starting to move towards Tableau, which is a little bit with some work on the front end, but we will get much timely reporting to the public because of it. And we can do a lot more sophisticated analyses than we could in Excel. So I don't think that was what you were referring to, but yeah, I think technology is going to play a pretty big role.
Yeah, I'm wondering if because the Green Mountain Care Board is an independent body, so you're not part of a state agency. But I'm wondering if we might consider down the road I don't know if we would do it or energy and technology would, but just support, seeing if the division of AI in state government might collaborate, because there might be ways that like the state of Vermont purchases access to or works with UVM or MIT or someone to develop an AI system for budgeting that various people in the state could use. So it's not like we're spending all this money just for one group. Because it sounds like, you know, it's a lot of work, and I'm not saying it would replace the humans. It just might be that you enter all that information into a machine and ask it to run different projections, and it can run multiple things quickly. And then you can look at that and kind of adjust it and then come back with like, I don't know. I just was wondering if it would make your job easier.
Yeah, definitely. And like I was talking about earlier, you know, a lot of what we do is really sniff tests. We receive so much information that we really have to, you know, make a judgment about
Did you
assumptions.
say sniff test?
Sniff test.
Is that like when you open the thing in the fridge?
Yeah.
Okay.
Yeah.
Don't laugh out loud.
Yeah. So we get all this material and, you know, use our experience. We're very good at reading financial documents and just like, hey, this utilization assumption doesn't make sense with what you're projecting over here. An AI model will pick up on that very quickly.
Yeah, but save you some time.
So, you know, I don't know what it would look like to build those things. I don't know what the time frame would look like for that. I know that stuff's rapidly improving. But that's the sort of stuff that I imagine it would do. It's that real time intensive manual,
Yeah.
like digging through Excel tables for hours. That's what I'm excited about.
Is there already doing it?
It is, yeah,
You can take it.
In your Excel work is not.
it's not. So, yeah, so I'll give you our, the hospital report cards. The Green Mountain Care Board provides financial data about that VDH publishes with the hospital report cards. It was a very time intensive process for us to build the spreadsheets to send over for that. And I'm talking like 60 tab Excel workbooks and stuff like that. We switched to Tableau. It's kind of a work in progress to make sure we're getting all the material there, but that's live on the VDH hospital report card website. So you can get in there and see, I think through 2017 up to the 25 budget, hospital payer revenue detail, expense growth, income statements, that kind of stuff is available now in a more dynamic way.
Great. Any other questions for Matthew? Okay, well, thank you for coming in. Thank you for your work. Hope you have some time off before your big season comes up. It's like being an accountant at
Budget
tax.
season.
Budget season is coming.
Always in the summer too. Which was winter.
Okay, so we are done with committee for today.